There we go. So it should be recording now. All right, so it's acute respiratory distress syndrome. Now, this is a syndrome that is non-cardiogenic pulmonary edema. Non-cardiogenic pulmonary edema. So why is it resulting in acute respiratory failure? You know, the four things that cause acute respiratory failure. It's impaired capillary diffusion. It's number 4. I think it has a different name now, but basically you're going through more than one cell thick. You're going to have to now have the oxygen flow through more than just one cell of the alveoli and one cell of the blood vessel. Now it's got to swim through water. And so people are going to become hypoxic because of this. Now, up to this point, you probably have only learned that pulmonary edema is from left-sided heart failure. That's the only kind of pulmonary edema that you have heard of. But other causes can be pulmonary edema than just a left ventricle that's not working. And this is an example of it. This is due to non-cardiogenic pulmonary edema, and it results in severe respiratory failure, which is by definition a PO2 of less than 60 with or without an increase in the PCO2. Now, there's lots and lots and lots of causes of ARDS, and look at all of these. Some of them are lung causes, and some of them are not lung causes. As a matter of fact, the most common causes are the ones that are not lung causes. The most common causes are the ones that these two top ones right here. Shock and sepsis are the two most common. As you can see, they are not the only ones. But when someone says someone's gone into ARDS, in my mind, I think they're either a trauma patient and they went into hypovolemic shock, or they were a septic patient and they went into septic shock. Almost all of them, not all of them, but almost all of them are caused by a decreased blood perfusion to the lungs. The lungs became underperfused. Not the only cause, but by far the most common cause. Now, I have written down for you the pathophysiology. This is not a pathophysiology course, okay? But everybody wants to know, well, how does that cause it? Now, I've got a picture of it, and I think the picture makes it easier to show you. And if you look at this map, and this is out of your book, by the way, the pathophysiology map, look what they say is the number one cause. Trauma, let me get my pointer up the top here. Trauma, sepsis, or another cause. But even they identify that trauma and sepsis are the two most common causes. If you say someone's in ARDS, I want to know what kind of trauma are they in, or what kind of septic situation were they in. And there might be others, but those are what immediately pops in my mind, okay? And so when we're talking about this, due to trauma or sepsis, you get an underperfusion. Not enough blood got to the pulmonary tissue. That's what shock is. Shock is an underperfusion, okay, to the tissues due to some cause, but it's still an underperfused state. That's the definition of shock, an underperfused state. And when it becomes underperfused, the alveolar capillary membrane, that one membrane thick, becomes injured. All right, and when it becomes injured, it can cause lots of different things. And this side over here causes some decreased lung compliance. So that contributes to the hypoxia, but that's not the big thing that happens. But it is one of the things that happens. It's not the one that we can really do much about. Well, we can't do much about either one of them. But the one that we really see is the one that's over here on your right-hand side. When the lungs become underperfused, it causes the release of some inflammatory mediators. We call these endotoxins. It releases bad chemicals, endotoxins, inflammatory mediators, some endotoxins. The lungs became underperfused, and these bad toxins are released in the lungs, right? And they start to change the permeability of the lungs. Now, when you hear me talk about change in permeability, and I'm going to talk about change in permeability right now, due to the release of endotoxins, I'm going to talk about change in permeability this afternoon in burns due to a different cause. I'm going to talk about change in permeability when I talk about anaphylaxis, when I talk about immune, okay? Shock usually results from a change in permeability at the capillary bed. What does that mean? It means the holes got big. So usually, not a lot of fluid goes out. Fluid just goes right on past in the capillaries, okay? But for some reason, the holes in the capillary got big. The permeability changed. And now you got some holes there that usually aren't quite that big. So fluid starts to seep out of the capillary beds into the tissues surrounding it. So you get this outward migration of blood and fluid, plasma, from the capillaries. And I have a picture next, okay? And then they even start to move from an area of higher concentration to an area of lower concentration into the alveoli. So I'm getting pulmonary edema, not because of the left ventricle and it's back sludging and pressure is increasing, but because of endotoxins, it's changing the size of the holes of the capillaries, and fluid can seep out those holes. And it's causing pulmonary edema, and now oxygen has to go through more than one cell thick, and they become hypoxic. So I'm getting impaired gas exchange, and they're getting ARDS from it. All right, so look at this. So this is normal. It comes in, it goes out the other side, okay? Goes in, comes, this is normal. The top one is normal. Well, I got a release of endotoxins, and the holes got bigger. The holes got bigger. And now fluid has seeped out of the capillaries, out of this vein to artery side, out of the pulmonary system. And now it's up here in the interstitial. It's not in the alveoli yet. It's simply between the vessel and the alveoli, because normally it's not there. Normally oxygen doesn't have to travel between there. But now it's having to swim between the alveoli and the blood vessel. And eventually it will start seeping into the alveoli. And now not only does it have to go through the interstitial space, it also has to go through the bottom of the alveoli. And now you're breathing in it, you're coughing in it, and it's giving you a frothy sputum that you're trying to bring up. Okay, and so you're starting to have this pulmonary edema that you're able to see, this frothy. If you've never seen pulmonary edema, just picture if they got an ET tube in, picture somebody inside the person's body with a can of shaving cream. And they're sitting inside the body, and they're holding down that shaving cream, and they're squirting shaving cream out of that person's ET tube. And you're like, suctioning. Oh God, suctioning, and you can't clear it. It's like shaving cream shooting out of their body. If you don't see as much pink frothy, you see that more with failure than you do ARDS, but you've heard of pink frothy sputum. You see that more with left-sided heart, with congestive heart failure than you do with ARDS. Typically, it's just clear. It's just white. Pink frothy sputum is because the pressure got so high in this that it sort of popped a little bit of one of these, and so blood seeped out with it too. And so blood gets in there and it makes it pink. That's what makes it pink. You might see blood with this. You could, but you see it much more than with left-sided heart failure than you do ARDS. I've seen it with ARDS, but you see it more with left-sided than you do this. Okay, so it's still pulmonary edema, but it's not due to a bad heart. It's due to a change in permeability in the capillary beds of the lungs due to a release of endotoxins, and that was due to an underperfused lung, usually. Now, this condition is very insidious. Insidious meaning it comes on very slowly. Okay. It comes on very slowly. Unlike a PE, which broke loose from the lower extremity, came up the vena cava, came into from the superior vena cava, went into the right atrium, went into the right ventricle, shot out into your pulmonary artery, and boom, stuck. And in one breath, I was fine. The next breath, I'm air hunger. A PE is a sudden onset, because a second ago, it was down in my leg. Now it's in my lung because it came from somewhere else. This is very insidious. It comes on very slowly, okay? And that's why it can be very, very difficult to pick up. So it has early signs: restless and a change in behavior, dyspnea, tachypnea, but the breath sounds are normal. You don't hear rails. You don't hear crackles. They might have a cough. The respiratory alkalosis is compensation, which we'll talk about when we talk about ABGs this afternoon. Tachycardia and their pressures are going to be high. Now, let's think about this. The most common cause is trauma. So I have a bad trauma patient that comes in. They're in a lot of pain. They probably have broken bones, maybe a femur, which could drop 3,000 cc's from a fractured femur. They might have broken ribs. They might have a head injury that could make them restless. They could be receiving lots of pain medicine that can make them restless. They could be complaining of a lot of pain. And a lot of times, especially with the trauma patient, this restlessness, tachypnea, and tachycardia is mistaken for pain. And so we keep giving them pain medicine, which I don't have a problem with, but nobody recognizes that they're continually not improving. And about on day 3 or day 4, they start becoming cyanotic. And you start noticing some circumoral cyanosis. And then we don't really catch it until they get into the late signs. It's a very difficult disease, or it's not a disease, a syndrome to recognize in the early stages, because it's not like I just come in and sit down. Typically, I am a very, very sick person to start out with. So it's hard to recognize these changes of behaviors. So it's very, very insidious. In the late signs, I'm almost to the point that I can't be reversed. I'm very hypoxic. My PO2 is less than 50. Remember, normal is 80 to 100. My PO2 is less than 50, but they're giving me high flow FiO2. So I'm on 60, 70, 80, 90, 100% oxygen, but I am still hypoxic. I am working hard to breathe. I am in severe dyspnea. I am grunting. Now, grunting is a terrible sign. Grunting, when a patient is, now it's not from pain, especially when you have an infant or a toddler who is grunting. That is a bad sign. Grunting is somebody doing their own peep. So normally when you exhale, your epiglottis opens and you exhale. When you are hypoxic, your body knows it. Your body is a great, whether you believe in God, whether you believe in the Big Bang Theory, whether you believe in, I don't care, the Easter Bunny. I don't care who you believe in. It doesn't matter to me. But whoever made the human body, or whatever made the human body, was one of the greatest minds or whatever that ever walked or ever didn't walk, whatever, I don't care. But the compensatory mechanisms is so great. It is amazing. So what they said was, this person's hypoxic. So instead of your epiglottis opening all the way and letting you exhale, the epiglottis is kind of kinking itself off like this. And so when you exhale, it's hitting the epiglottis so that it's sort of forcing some oxygen back down, some exhaled back down, keeping some pressure in your lungs on expiration and making you to have your own PEEP. But when it cuts itself off, it makes a sound as it goes through there, sort of a, you're not doing it, I'm doing this, but you don't realize you're grunting when you grunt. So when a patient comes in that's grunting and not from pain, that's a very bad sign. That's an assessment finding that you go, oh, not good, they're making their own PEEP. They are hypoxic. So grunting with expirations. They are tachypnic. They are tachypnic. Therefore, they are hypocapnic. When you are tachypnic, you are blowing off your CO2. So they are hypocapnic. They're also hypoxic because of their pulmonary edema. I said something wrong a minute ago. I said they were in respiratory alkalosis. That is not compensatory. That is because they are tachypnic. And tachypnia, you blow off your CO2, and your CO2 is acid. Therefore, that is, you're in respiratory alkalosis. They now are into 4 or 5 days. Therefore, they are compensating. So they are now in metabolic acidosis, which is your compensation. I said that wrong. Now you start to hear breath sounds. Now you start to hear adventitious breath sounds. Breath sounds have sounded good. So you're thinking, oh, they're great. Their breath sounds are good. 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 No, their breath sounds aren't so good. You don't hear abnormal breath sounds with ARDS until they're pretty much in trouble. And on a chest x-ray, you'll see your patchy infiltrates. Now, when you read a chest x-ray, or when you read any x-ray, okay, white is fluid, black is air, and gray is tissue. So when I look at this person's chest x-ray, this should all be black. This should all be black, and it's not. Look at all this white in here. This is all fluid in their interstitial spaces. Now, this is all fluid in the interstitial space up in here, too. Now, their heart is sitting right around in here. So it typically comes down and you get a heart right here. But this isn't. This is all fluid that air can't get through right in here. This right here is their diaphragm. Okay. But this, and of course, these are ribs. There's their ET tube right there. You can see it coming right down there, right down here. Okay, and that's actually, and an NG tube's in there too. So you come down through here, but this should all be gray. Excuse me, this should all be black. Oops. I'm trying to get back to it. This should all be black, and it's not. We call that a whiteout. When both lungs are sort of almost all white, we call that a whiteout, and that is a classic sign of ARDS, a whiteout. And it's like one day it's black, then one day it's all white. It comes on very insidiously, very slowly. So it's ARDS. It is acute respiratory failure. So the impaired gas exchange. What is the definition of acute respiratory failure? Hypoxia. It is a gas exchange from multiple causes, but it is a low PO2, so impaired gas exchange. These people are dyspneic. They have difficulty breathing. They are tachypnic, so they also have ineffective breathing along with that. They now have frothy sputum, so their airway clearance is difficult. So they have impaired airway, right? They have ineffective nutrition because they're not eating and they've been in the ICU now for several days. And so we need to make sure we keep their diaphragm strong. So they need some type of nutritional support. They are anxious. When you can't breathe, you are anxious. So there's anxiety here. This fluid all in their lungs is a great prime medium for infection. So they are at high risk for infection. They can get an overgrowth of pneumonia in there, and that can be devastating. So these are not all, but some of the prime nursing diagnoses that we might see with this patient. So what do? They're hypoxic, give them oxygen. Almost, and I could almost say 100% will be sedated, intubated, and ventilated. we will put them on a ventilator. They will go on a volume cycled ventilator. Maybe they might even need more than that, like an oscillator. It all depends on what their progression is. They often will need PEEP because they will keep getting more hypoxic, more hypoxic, more hypoxic, even though we keep increasing their FiO2. So we're going to, quite often they will be on PEEP. They were usually a trauma patient. We need to check their hemoglobin levels. They have to have an adequate hemoglobin to carry enough oxygen around. We try to keep them between 25 and 35. But that's our goal, 25 to 35. Not always accomplished, but that would be our goal. A hemoglobin between 25 and 35. No, that's a crit. That's a crit. I'm sorry, a crit between 25 and 35. I'm sorry, I'm so sorry. Not hemoglobin, but we do want an adequate hemoglobin level. We fool with crits more than we do hemoglobins, but of course, crit is your concentration of your hemoglobin. We want to keep them in fluid and electrolyte balance. Now, this can be really tricky because it was caused by fluid volume deficit, but their lungs are in fluid volume overload. So this is a real titration dilemma. We got to keep their blood pressure of at least 100 systolically, but we don't want to overload them, but we don't want to let them die from fluid volume deficit either. So it's a very, a one-on-one, a very tight watching and titration of this patient. It can be it's a game. It's a game of what's too little and what's too much. Quite often they might need diuretics, but we can't drop their pressures because that'll make the endotoxins be released again. So we got to keep their pressure up, but we can't get them too high because that'll increase their fluid volume overload in their lungs. But we can't let their pressure drop because that will cause them to have endotoxins released, and that will open up the permeability of their capillary beds. So it's a tough one. It is a tough one. They are tough patients to manage. And then, and we also typically put them on prophylactic antibiotics because their lungs are at such risk for infection. And then, of course, they need either enteral if their gut is working or TPN. That will help to keep, they keep their diaphragm strong. So what else? Oxygen therapy. We always want to use the lowest amount of oxygen that meets the patient's needs. If you're using just nasal cannula in your regular patients and their pulse ox is 100, then turn their nasal cannula down. 30 minutes later, take their pulse ox again. If they tolerated that, turn their nasal cannula down by 1 liter or half a liter or whatever. Always use the lowest amount of oxygen that meets the patient's needs. If they need 100% FiO2, then give them 100% FiO2. If they don't need it, then turn their oxygen down. We always want to use the lowest amount, but it needs to meet the patient's needs. Because oxygen can be toxic. It destroys the alveolar unit. Let me put it this way. It can destroy the alveolar unit. So we always want to use the smallest amount for the shortest amount of time. Now, some people are on it for their life, but most people don't use high flow oxygen or high amounts of oxygen for their life. And so early signs are they might have a cough, they might have some shortness of breath, they might often have bronchitis or tracheobronchitis, and some people their alveolar units just get really, really fibrotic and gas exchange can't take place at all, and it will kill them. Who gets death from oxygen and who doesn't, I don't know. It's all what does your body tolerate and what does your body not tolerate. So I don't want to say, well, I think that one's going to die and I think that one's not from oxygen toxicity. Let's always use the lowest amount of FiO2, but don't let your patient be hypoxic. That's the key. You don't let somebody sit there with 100% O2 on with a pulse ox of 100%. turn it down. But if it makes them hypoxic, turn it up. That's what you do. That's why you're a nurse. You're making some clinical decisions, some critical thinking. Make those decisions.
Katie.
Yes.
So with ARDS, since they have all the fluid, would it cause barotrauma for them to suction all the fluid, or would it just produce more?
Produce more fluid by suctioning them?
Yeah, like if they were caught with the frothy sputum, if you were to like keep suctioning it to get the fluid out of their lungs, that would just cause more.
No. You would want to suction them. You would want to suction. You've got to clear their airway out. The key is to get them to stop producing it. That's the key, by getting them out of fluid overload. And I'm going to talk about that in just a second. Okay. But yes, you have to suction it. ABCs, airway is always your highest priority. Always. You've got to clear their airway out. You've got to suction them. You have to.
Hey, Janie.
Yep.
You wouldn't do a thoracentesis, right? Because that will cause like more infection.
Well,
possibly.
Well, if you need a thoracentesis, you need a thoracentesis. But this person's problem isn't a pocket of fluid in a specific area. And a thoracentesis is a pocket in a specific area. This is throughout their entire lungs. Remember, the whiteout is the entire lung. So a thoracentesis isn't going to help this person.
Gotcha. Okay.
Thoracentesis is for a specific area. It wouldn't help them. This is in every interstitial space in their entire lung is leaking. We've got to stop their permeability, that change in permeability, the increased permeability. So what do? Well, number one, we got to not over give them too much fluid. So we kind of talked about that. Careful titration. We've got to treat their hypotension, but we cannot give them too much fluid. So we got to watch. They're put in the ICU. They're on a ventilator, and we're going to watch them very, very carefully. So minimum amount of fluid, but don't let them be hypotensive. That's first off. That's going to cut down on their fluid volume excess. We got to treat them that way. If they're in severe and their pressure's up, then of course we're going to give them diuretics, but only if their pressure is up would we use diuretics. Only. If their pressure's down, you can't give them diuretics. So again, it's so individualized. We have to treat their nutrition. I think I've already talked about nutrition. We've got to keep them, we got to keep their diaphragm strong, so they're actually going to get TPN or enteral. So I've talked about that. Okay. So this also is important because nutrition helps stop the endotoxins. So nutrition is essential. It's essential to stop endotoxins. Now, the complication with ARDS is that most people that develop ARDS will die. You almost can't stop it. It used to say 80 to 90% will die. The latest edition of your book says 50 to 90%. So we're doing better. We're doing better. But most people, if they get to ARDS, they will probably die. And so you have to help families understand that the chances of recovery are very, very slim. The key was not, like in the ED or on EMS trucks or whatever, is not to let the patient become hypotensive in the first place so the lungs did not get underperfused. Not let your patient become underperfused. But ARDS is tough. Once they develop it, they will probably die. Don't have to, but they probably will. So help them. The anticipatory grieving of death is very tough.
Is there any information on if they recover, if they have any disabilities or anything after?
Here it is. People that don't die, 85% will recover with no disabilities at all by 1 year. So if they do live, they're fine. Their lungs are fine. About the other 15% may have some lung decreased airflow, maybe exercise hypoxia or exercise dyspnea on exercises, that type of thing. But if you were to live, your chances of recovery with no significant effects will be very high. But most will not live. And you got to help families to understand that they will not live. Most will not live.
Miss Janie,
Yes.
would you say that the mortality rate is so high because it's not caught until so late?
Well, it's not caught or that we couldn't stop it, one or the other. The endotoxins just kept getting released and we just could not stop it. But a lot of it's because it's not caught.
Okay,
Because
thank you.
it's trauma patients and they keep dropping their pressures. And we can't stop the endotoxin release because they just keep dropping their pressures. A
Oh,
lot.
Janie, there's no like antibiotic, no any kind of treatment like that helps it. It's just you're trying to keep the pressure stable and
The body,
secretions.
I hope the body says, oh, I'm better. Close down my holes. Close your holes.
Miss Janie,
Yes.
so I know with kids, we use high flow like a lot before we go into intubating. Is that also with adults? Do we? go
Yes,
to
we use
flow?
high flow before intubation for almost everybody because most of the time we will use a paralytic. We'd already talked about chemical paralysis. So they have no gas exchange taking place before intubation. So we want to, fill up every single hemoglobin with all the oxygen so that they have good oxygen while the patient's not really breathing. And that'll give us a little bit more time to intubate. So yes, we use high flow oxygen before intubation. And then once they're intubated, we can bag them real well. And then we'll see what their oxygen needs are after that. We'll use it. We have to use it individually. Yeah, high flow. We use 100%. You bag with 100%. Yes. That's high flow, 100%. So here's my little lady. There's really nothing between a man and a woman, except that it's about 2 to 1 to almost 3 to 1 times more trauma in men than there are women. This is a woman in this picture, but typically we see more ARDS in men only because we see more trauma in men. Okay, not really because ARDS is more prevalent in men. Like it's not their lungs, it's because of the causative agents more prevalent in men. So tachypnea, dyspnea, retractions, meaning that they're sucking, not taking good deep breaths, hypoxia, tachycardia, and crackles. Okay, so those are some signs. They're on the venomatic, that would be the rest ventilator, and notice their lungs are white out. Okay, their PO2 is down and they're not getting any better. They're worse and they're worse, but they're not getting any better. Okay, causes, even on this slide, and I didn't make the slide, massive trauma. Number one cause, trauma. Number one cause, trauma. Do you recognize what is trauma? God, I don't know how to make it any plainer than that. If you don't think you're going to see a question about, I don't know, I haven't seen the test, but typically there's a question about trauma on the test. Okay. And remember, it's not just, what is it, trauma? Can you recognize a trauma patient? Okay. Come on, I already gave you about 3 test questions. Okay, here we go. There we go. That's ARDS. Most people do not live. All right, other things about finishing up on respiratory is thoracic surgery. Thoracic surgery is not just your lungs. In your thoracic cavity, you have your heart, you have your lungs, you have your mediastinum, you have your esophagus. All of those are in your chest. So when we talk about thoracic surgery, it's not just your lungs, but you're going to have to open the chest. Where do they open the chest? It depends on what procedure you're having done. So it could be straight in the middle of your chest, like for cardiac surgery, it's typically straight up and down, straight in the middle of your chest. Anterior procedures are typically for more simple lung surgeries. Massive lung surgeries are typically done in the back. They're usually posterior type procedures. So it all depends on what type of procedure they're having done is what determines where your incision line is going to be. So there can be lots of different kinds of procedures. Anytime there's a surgical opening into the chest, it is called a thoracotomy. Whether any surgical opening for any type of procedure, it doesn't have to be lungs. Now, when they open your chest, you are going to have negative pressure breathing through the hole. So you breathe through your nose, you breathe through your mouth, and you will breathe through your hole. It's not good breaths, but air is going to suck in through that hole, and it's going to collapse the lung underneath that hole. Okay? So they will have to put in a chest tube to reinflate that lung. It will pull the air out of there. It will pull the blood out of there. And that will allow the lung to come back out to the chest wall and to reinflate. The purpose of the chest tube is to reinflate the lung that collapsed due to the thoracotomy. Most thoracotomies will require a chest tube to be put into place. I will tell you which one does not in just a minute, but most require a chest tube to be put into place in order to re-expand the lung that got closed down when the opening happened and negative pressure rushed into the chest and collapsed the lung underneath it.
So if like you had the medium like down your sternum, would you have to put two
Medium
chest
sternum?
tubes?
Mhm.
Yes. Would you have to put two chest tubes in, or just?
Well, it depends on where they're going in. Depends on where
Okay.
they're going in. If it affects both lungs, yes. Now your lungs are in two completely different cavities, okay? So collapsing one does not make the other one collapse. So it depends on where they went in and what angle they went in to. So yeah, it depends on whether it collapsed both lungs or not. So it could be individualized. Oh, what was I saying? Oh, so with that said, all you have to know for test one is if the lung is collapsed for a thoracotomy, a chest tube would be used. You do not have to know the care of a chest tube. That is test 3. So I'm not going to ask you about care of a chest tube on test 1. Okay? You just need to know that if you have a thoracotomy, in most cases, you will need a chest tube to re-expand the lung. If not, the lung will be collapsed. All right, so if you're going to have a thoracotomy, pre-op, they're going to see what your lung function is pre-op, so they will know what to expect post-op. So you're going to have ABGs, good baselines. What's your tidal volume? You know, what do you look like on a chest X-ray? What's your ABGs? What's your normal blood chemistries? So they want a good baseline from you so that they know what to expect post-op. We're going to ask you to stop or decrease smoking. I gave up on that a long time ago. I had so many smokers on my unit because I worked a cardiothoracic unit when I first got out of nursing school. And it's really sad. And the sad thing is you don't see symptoms for 30 to 40 years. Therefore, why, when you're 20, would you stop smoking? You have no symptoms, and it's not going to happen to you. So why do you need to quit smoking? Well, because I've never held somebody's dying hand due to COPD, due to lung cancer, who looked up at me and said, I am so glad I smoked. I have never. They all looked at me and said, was I stupid or what? Well, you never will convince somebody that smokes that's bad for them. You'll never convince them. Never. So I gave up a long time ago. I mean, it's not that I don't encourage it. I'm not saying that, but because you don't see immediate symptoms, you can't convince people. That's just all there is to it. We do typically put them on antibiotics pre-op. The lungs are an area that gets terribly, terribly infected. And so we often will give them antibiotics pre-op for lung surgeries. And then good pre-op teaching. How do you cough? What should you expect? Are they going to be intubated? Are they not going to be intubated? Are they going to have a chest tube? What is a chest tube? It's not a ventilator. It doesn't give them breaths. You know, would they go to the ICU? Will they not go to the ICU? What is it that they're having done? Where's their incision line? Many people do not expect their incision line on their back, and they don't realize how difficult it's going to be to lay on their back and how much it hurts to lay on their back. And so education, so people will do better post-op if they understand what it is before they go to surgery. Pre-op teaching, the art of pre-op teaching has almost been lost because of coming in the morning of surgery. But pre-op teaching is essential. If you happen to be a nurse that chooses to go to a doctor's office to work, encourage your docs to have an education office. And you're the RN. You shouldn't be the one that just puts them in a room and say, the doctor will be here to see you shortly. You should be the one that says, can I have an education room? And as before they leave, you say, come on, Mr. Jones, you're having surgery next Friday. Come in here, let's talk about your surgery. That should be your job as the registered nurse. You got to find you a doc that will pay you to do that. That's about the only docs that do that are OB doctors. They have OB nurses that do education. But it's hard to talk to the other doctors. The surgeons really need a good educating nurse. They're doing better, but not great. So what are some of the complications? Well, post-op, we got to get that lung expanded, but sometimes the alveoli don't pop open, so they can have atelectasis. So, we need to get using the incentive spirometer. They need to turn, cough, deep breathe. They need to take those good deep breaths. We got to keep those alveoli as open as we can. Again, pneumonia, we got to monitor for early signs of pneumonia, increased temp, increased white count. We again need them to walk. We need them to cough. We need them to turn. We need them to move. How do you get them to do that? You give them pain medicine. You will not get a patient to turn, to cough, to walk, to do anything if you don't get their pain under control. Yes, morphine is a respiratory depressant, but not typically at less than 8 to 10 milligrams. 2 to 4 of morphine is not a respiratory depressant unless you're working hospice. That might do it, but not on a typical patient. 4 milligrams of morphine is not going to depress my respirations. I promise you all. And I don't even take narcotics of any kind at any time. I mean, I probably haven't had any kind of narcotic in, I don't know, probably 20 years. And I promise you, if you gave me 4 IV push right now, it would not affect my respiratory rate. It might put me to sleep, but it won't affect my respiratory rate. 8 to 10 IV push becomes a respiratory depressant, not 2 to 4. We all know it's a respiratory depressant, but we don't look at the dose. Hemorrhage, the lungs are very bloody, and you can get hemorrhage from that. Cardiac dysrhythmia is usually due to hypoxia. Come on, somebody. Rogers, you're first on my list there. Tell me the most common dysrhythmia due to hypoxia. Do you remember? You're muted. Unmute yourself.
Sinus tachycardia.
Sinus tachycardia. If the myocardium is hypoxic, what is the most common dysrhythmia?
PVC.
PVCs, very good. Those are the 2 dysrhythmias you're typically looking for. Very good. You can get pulmonary edema. Not common, but you can get it. Okay. I'm going to skip down to empyema real quick. Empyema is pus in an enclosed cavity. That's the definition of empyema. We usually think of it as the lungs because the lung is a very enclosed cavity. So they could get pus in their chest. That's what empyema is. So they could have pus in there. A bronchopleural fistula. A fistula is any unnatural tract. That's the definition of a fistula. You got a tract from one place to another that should not be there. So you got a tract between the bronchus and the pleura, the lining. Okay, so this shouldn't be there. Okay, and so they've had lung surgery and they clamped off the bronchus, but a little something has started to wiggle through, and now it started to track its way through to the lining of the lung. Okay, and so these people start to develop a fever. Air came out of the bronchus. You're breathing in. That tract is being formed mostly by air. Air is worming its way through, trying to get out. And so you're going to get sub-Q air. That's called sub-Q emphysema. That's the correct medical term, sub-Q emphysema. You probably called it crepitus. That's that Rice Krispies under the skin. It's trying to get out of the body. It's trying to move from a high concentration to a low concentration. Okay. It's going into the tissues. It's causing a little bit of blood. So when they cough, they might have streaks of blood in their urine. Listen to me, in their sputum. It'd be tough to get urine up there. If there's urine coming out of their mouth, we're in bad shape. And then in their chest tube at about 3 days, because at first they don't have it. It's taken a few days for this to happen. They will have a severe air leak. Now, you don't know what a severe air leak is. You don't know how to check for a severe air leak. You won't know that until test 3. But a severe air leak at about day 3 is a sign of a bronchopleural fistula. Okay. All right, I'm going to keep going, but we are going to break. I just want to go through finish the lungs. A lung biopsy is another thing that's done, and of course, a biopsy, like anything, is to determine if some kind of tissue is benign or malignant, just like any biopsy. And in this case, it's a lung biopsy. It can be done 2 ways. They can either do transtracheal, where they go down through your mouth, like with a bronchoscopy. And it's usually for more of the upper lesions, something that they could get through your trachea. Or they're going to go through your side. If it's a lower type thing, they're going to go through your skin. And if it's through the skin, it's called percutaneous. Cutaneous is skin. So it's either transtracheal or percutaneous. And depending on which way it is, it makes a big difference, okay? If it's by bronchoscopy, they'll probably just give you some sedation, like conscious or moderate sedation, kind of put you in la-la land, knock out your gag and cough reflex, and they'll go down with a scope, a bronchoscope, go through your trachea, down to your bronchus. They'll find the lesion, and they'll either clip it, get a little piece of it, or they'll take a brush and they'll brush it really, really hard, knocking off cells, and then suction it, puts a little saline down there and suction off those cells and send that through. And they'll send that for histology and look for any signs of cancer. Post-op, we've knocked out your gag and cough reflex. Do not feed them until they get their gag and cough reflex. Monitor their respiratory status until they wake up, and we give them, and we don't feed them or give them any problems. We just need to make sure we monitor the respiratory status so they wake up and their gag and their cough comes back. It is very common for them to have streaked blood in their sputum because they got stuff clipped out of there. They got stuff scrubbed out of there, but it shouldn't be clots of blood. But streaks of blood is very common in their sputum, okay? Percutaneous, they might sedate them, they might not. Well, they typically would. And they will go in and they will numb the skin, and they'll simply go in and they'll look at the the lesion, and they'll either aspirate back with a big old syringe, or they'll do a punch biopsy and get some of the cells out of the tumor. If it's bad enough, they'll go to surgery, and they'll simply just open the person up, and they'll take the whole mass out. That would be an open lung biopsy. Typically, if you're going to have lung surgery, they'll just take the whole thing out. Okay. And the video-assisted thoracic surgery called VATS, that's pretty much it goes through the skin, but it's more invasive than just a punch. They actually go in and they find it, and it often results in the collapsing of the lungs, and you have to have a chest tube put in, as does the open lung biopsy. The punch biopsy does not. It doesn't collapse the lung. The open does, as does the VATS. Both of those are much more invasive than just a punch biopsy would be. So punch biopsies are going to have to be closer to the skin. If it's deeper, you're going to have to be opened up and have lung surgery. And if they're in there, they're just going to take the whole thing out. They're not just going to take a biopsy and say, well, if it's positive, we'll go back in again. They'll take the whole thing out. So as far as nursing responsibilities go, again, I told you, prevent their aspiration. If it's transtracheal, assess for any respiratory distress on both of them. Frank bleeding, we might get streaks of blood, but we should not have frank bleeding, big clots of blood. And for the punch one, you want to watch for any signs of a pneumothorax, severe respiratory distress, unequal chest movement, unequal breath sounds. You see those with the percutaneous. You don't see that with the bronch. And the last one is a thoracentesis. Now, someone mentioned about, oh no, it's not last. The thoracentesis would be for a pocket of fluid. And when they're going to go in and drain that pocket of fluid, and this is done typically at the bedside. The patient is not put to sleep at all. They're not sedated at all. The patient sits up and usually leans over their bedside table, just put a pillow on their bedside table. And the doc will numb their side. And when you sit them up, that fluid will go down into a pocket right there. So you've got a nice little pocket of fluid. They usually had a chest x-ray before, so they know exactly where that pocket of fluid is, under which rib they're going. They'll numb the skin. They'll put a needle in there, not a real long needle, a little short type needle. It's connected to tubing, and on the other side of the tubing is another needle. And if you've ever seen in the clean utilities rooms, there's a huge, it's usually at least a 2 to 3 liter clear bottle. Doesn't have anything in it. It's usually sitting on the floor in the clean utility room. It's a vacuum bottle. So they stick this side in the patient, they put the other end in that clear vacuum bottle, and it sucks fluid to it. And it pulls the fluid out. That's the way it's done. Typically, you'll get anywhere from 700 to 1,000 to 2,000 cc's of fluid out when you do a thoracentesis. Now, when you see the word centesis, your biggest responsibility post-procedure is to watch your patient for signs of hypovolemia. If I pulled 2,000 cc's out of this person's chest, my hope, well, first I say to myself, well, where did that 2,000 cc's come from? Yes, it was sitting in their lungs. Or when Jane talks about a paracentesis, when she talks about liver failure, yes, it was sitting in their right upper quadrant. But where did it come from? That's the question. It came from the circulating blood volume, and it got pushed out into the interstitial space, and it just sat as a pocket of fluid there. I now pulled out that 2,000 cc's, and now I've kind of got a hole, just an empty hole. My hope is that maybe as the capillary bed goes past it, maybe it'll just go drip. And maybe an hour later, I get another drip into the hole. And maybe 2 hours later, I get a third drip. And maybe another 2 hours, I get a drip. But what if they pull that 2,000 out and I get drip, 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 and it fills that 2,000 up in 15 minutes? It comes out of my circulating blood volume, and that's going to pull it's just like opening up and put 2,000 cc's of blood out on the ground. It comes out of the circulating blood volume. So our hope is that it comes back slow over 6 months, or a month, or 2 months, or 6 months, or a year, or never. But what if it comes back in 15 minutes? So monitoring for signs of hypovolemia after you see the word centesis is a major nursing responsibility. It came from the circulating blood volume. You took it out, but the hole now gets filled back up from the circulating blood volume. Important, important. Okay. I don't know, I haven't seen the test. All right, last two things, and that is removal of the lung. There's two procedures. One is a lobectomy and one is a pneumonectomy. Now, a lobectomy is a removal of one of your lobes, and you know you have different lobes. You have a different number of lobes in your lungs. So if I go in and I go in my right side of my chest, doesn't matter which side, if I go in my right side of my chest and I remove only one of my lobes, I have other lobes that are still left, okay? So when I removed that lobe, the other lobes collapsed. So there must put a chest tube in there to re-expand the lobes that collapsed. All right. So now I'll come back to the slide. On a pneumonectomy, you take out the entire lobe. At the bifurcation, they simply tie it off, clamp it off, tie it off, and they take out the entire lung. There is no lung to re-expand. Therefore, a pneumonectomy does not have a chest tube. Remember I said most thoracotomies have a chest tube? This is the one that does not have a chest tube. They might put a drain in there just to get some of the serous sanguineous stuff that's kind of collecting in there, but it does not have a lung to re-expand. Therefore, it does not have a chest tube. So positioning is very, very important. Positioning, let me go to the next slide and then I'm gonna come back. Who gets a pneumonectomy? People that have massive cancer would lose all their lobes. We used to do it a lot for unilateral TB. They used to take your lung out. We don't do that too much anymore. But again, no chest tube, the lung was completely removed and it'll just solidify type thing in there, all right? So when we're gonna have lung surgery, you're going to explain to the patient what's going on, but we need to position them correctly. Positioning is very important. Now, the best way I can explain this, rather than learn operative side up, operative side down, is you want to make the lung that's left have the least amount of work. So when I have a lobectomy, let's just say I'm doing right, okay? The lung that's not very good is my right lung, because my left lung was fine. I didn't have surgery on my left. So I want my right lung to have to do the least amount of work because it had surgery. So when I position my patient, I put them on their back and then I put them on their left side so that the right lung pushes against the least amount of resistance. If I were to push them this side down, then my right lung has to lift the left side of my body up. And then it's not going to breathe. It's like getting squashed. So I can put them on their back and then it breathes pretty well. And then I position them on their left side and now it's not pushing against anything. So it has good excursion. Okay.
So basically, don't lay them on the side that they were operated on.
Well, I don't want you to say that, but
Okay.
yes, but I don't want you to say that. I want you to think about how hard which lung do you need to work the least and put it up.
Okay.
And in a lobectomy, it's the one that had surgery, right?
Mm-hmm.
Now think about a pneumonectomy. In a pneumonectomy, this whole side is gone. There is no lung in this side. So I have to protect the left one. It didn't have surgery, but it's the only one I got. So I put them on their back. And when it's time to position them, I put them on their back. 2 hours later, I got to turn them. I turn them with the operative side down because this side, the only one they're breathing out of, I want it to go up and down, up and down. I don't want it to have to push against this side of my body because there's nothing there to breathe out of. So you want to think about how do you get the best gas exchange? How do you get that lung to have the best gas exchange? There is no right-hand lung, so I don't care, right side lung, so I don't care. It's my left lung that didn't have surgery, but I still want it to have the best gas exchange because it's the only one I got.
So that one you keep up is what you're saying, the one that you didn't have surgery on. So if your left lung was removed, you would put it on that side because you need your right lung to perfuse more. So you would keep it up. Is that what you're saying?
Yes.
Okay. All right.
Ventilate more, not perfuse, but ventilate
Oh,
more.
sorry. Ventilate. Sorry.
Yes, correct. Correct. So there's much, and I don't want you to say operative because it's not operative that's the problem. It's the lung that's the problem. That you want to make sure your lung has the best oxygenation. That's why I kept saying, yeah, but don't say it that way. So just a couple less things, and we're going to break. Anxiety. You know, when you can't breathe or when you have lung cancer or anything bad or ARDS, anxiety is a really big thing. Try to help people. Pre-op teaching will help decrease anxiety post-op. Letting them know where their incision is, letting them know what environment they're going to go to. You have lung surgery and you go to CVRU, you will walk. You will sit up and get up out of the bed the first night post-op, even in the ICU. You have heart surgery, you won't. But if you have lung surgery, you will. We will get you up. What kind of tubes to expect? You're in pain, ask for it. Ask for it. We will give it to you. If you've got a calm family member, use them. You got somebody a little bit out of control, not so good. I know COVID might break down how much family we can use, but if you've got a family member you can say, now every 2 hours, give them this pillow and let's show them how to cough, have them cough for us. Use your families if you can. If they're not real helpful, if they're just bothering the crap out of you, they don't use them, but use what you can. But we want them to cough. We want them to deep breathe. We want to turn them every 2 hours on the appropriate side. We splint and pad. You all know how to splint and pad using the incentive spirometer, we still want to do passive range of motion. If they have this surgery, it's going to hurt to move this arm, but we want them to use that arm. So you still want to use passive range of motion. You still want to do everything you know about the post-operative patient. None of that is new. Breathing, this all is the same. Pain medicine will help. Pain medicine will help. There's no question. You might teach them to huff a cough instead of cough a cough. That's a whole lot less than big old coughs. But at first they may need to huff a cough. Teach them how to cough. If they're getting PMPD, we don't percuss right smack on the incision line. We go around the incision line, but we do not percuss right on an incision line. It can disrupt the incision line. So we don't do that. Give them pain medicine. They will move, they will cough, they will do everything better if you will medicate them. Pre-medicate them before you want them to walk. They will walk better for you. Range of motion, put the articles on away from their bed. In other words, if they had right-sided surgery, put the overbed table on the left. No, don't put it on the right. I'm so sorry. Put it on the right. Don't put it on the left. I want them to reach with that right hand to get their tray. I want them to reach with their right hand to get their cell phone. I want them to reach to get what they want. I don't want it over here on the left. They can use their left hand all they want. I want their glasses and their things over here on their right. If they had right-sided surgery, I want them using their right hand to do their stuff with. Put their articles in their environment on the side that they had their surgery on. Teach them to stand up straight. Just like a mastectomy, we do the same exercises with them as we do a mastectomy patient. Put your set against the wall and put your back against the wall and stand up straight. If not, they'll start to hunch over because it hurts to stand up straight. So we do exercises and posture exercises, which are very, very important. I think this is almost the last one. Yep, their stamina is going to be less. They got less lung. They're not going to possibly be the runners they were before, maybe. Maybe a change in lifestyle. Maybe they got to think about their house and their bedroom. Maybe there was a guest bedroom downstairs. Maybe they need to move downstairs because they can't walk the steps as much. Just what kind of change in lifestyle? And then what type of exercises, posture. We talked about pain relief, planning their activities with periods of rest. No smoking. All right. They shouldn't lift greater than 20 pounds and report any respiratory infections. They need to be treated very promptly and make sure that they do their follow-up appointments. All right, it's 10:11. I will see you all at 10:21, and we're going to do the last section is ABG's compensation. So we're going to talk about compensation. It doesn't take an extremely long time. All right, I'll see you all at 10:21. I'll be here if you have any questions. My nose itches. Okay. Oh, do I have people still out in the waiting room? No. Okay. I think that was from before. Pardon me.
Oh yeah, Janie, I have a story you might appreciate
Okay.
from
I like
from this past weekend. Saturday we had a trauma actually come in to, if you know anything about Pineville ED, we're not a trauma hospital at all. And but we had a trauma come in and we didn't know she was a trauma because medic brought her in as a priority 3 and dropped her off and was like, cool. So she went up to triage. Well, turns out she'd had a fall and broke a bunch of ribs. And she had a hemopneumothorax.
Oh, really? That's good.
Uh-huh. And she was a chronic alcoholic with a baseline hemoglobin of like 5.5. And so we had to intubate and chest tube her at the same time. And we were talking to the docs and it was really interesting because they were like, well, we could potentially do a thoracotomy if it really took that kind of, and I was like, there's no way, because we're not a trauma hospital. We don't have that kind of, but we have the supplies for it. So I was like, there's no way. I mean, yeah, but they were like, but we'll try this first and see how this goes. And so they stuck the chest tube, like they intubated and chest tubed her at the exact same time. Like it was intubation, chest tube. And then she drained like 2 liters of blood onto the floor.
Wow.
Yeah.
What do you mean onto the floor? They
Like-
didn't have a system, they didn't have a set up for her?
So I don't remember what the reasoning was, but it was like there wasn't enough. I don't know why they couldn't do it. I think it had something to do with there was too much pressure, and so they didn't want to hook it up to anything until they knew that it was actually going to drain. And so I don't know what the deal was, but they were like, yeah, it's so he stuck it in, and all of a sudden you just hear just blood just pouring out. We were like, oh, okay. And so one of the nurses was like, can somebody get me a bucket? And so it was wild. She got shipped up to Maine. I don't know. The prognosis didn't look good for that one, but
You probably never heard of this, but I would think one of your nurses should have, but maybe not, because you probably don't do it enough. We don't do it a whole lot at Maine, but an experienced nurse would know how to do this. Your chest tube setup. Now, I don't teach this because it's not a beginning practitioner thing, but you know, your chest tube setup, you know what I'm talking about, your drainage system.
yeah.
Chest drainage is one of the few drainages that you can actually just turn around and give it right back to the patient.
So there's a nurse, one of the people that actually got me into nursing, I was talking to last night, and she told me the exact same thing. Is that there's
It's an auto transfusion.
Yeah, there's a device that does that. And I was like, I don't know if we have those.
It's
or
the same thing. It's not anything different. It's exact same system, but it's the thing that's different is it's the drainage bag. And you probably never.
Saturday, we had to put a chest tube into. We had a 17-year-old, 5 stab wounds to the back, 1 to the chest.
Oh,
Yeah.
that's rough.
So his right lung.
Have it. I can't. This one does not
That's
have
rough.
it. But usually on the bottom of your system, this one's pretty old. There's another little tube. It just looks like. Well, it doesn't look like any of these, but it looks almost like the same material as the chest tube. It's kind of clear looking.
Huh.
And it comes out the bottom of the drainage side, and it usually comes out, it's just hooked right up here. And you hook the end of it to a bag. It's a bag. It looks like a IV bag, a small IV bag, like a 500 IV bag.
Yeah.
But when you pop the IV bag open, it's spring loaded. And so it sucks blood. So as the patient bleeds into the drainage system, it sucks it into the bag. And then you disconnect the bag, close the clamp, disconnect the bag, and you can take that bag, hang it right back up, and give it right back through blood tubing, regular blood tubing, and give it right back to the patient.
Is it kind of like one of those I don't know if it's called a wound vac per se, but it's the ones where it's like it's just a spring inside of a bag. Then they have them sometimes for wounds, and it's just.
Well, the
I've
one
seen
that
those
you
before.
see, was it on an orthopedic unit?
I think it was. I was in maternity pod, which was our little small post-op.
You can give back knee drainage. You can give back joint drainage that way. Yeah, and it's a spring-loaded bag. Yes, it is.
Cool.
Uh-huh.
Yeah, I didn't know
You can
that.
give back lung drainage. You can give back, and you can give back knee drainage, or I guess maybe a hip. But I really haven't. Hips don't bleed like knees do. Knees are much worse than hips are.
Yeah.
And even recovery knees are worse than hips are.
Yeah.
And so, but you can drain from a knee and give it back. And it's a spring-loaded IV back, and it like sucks it out, and you can hang it right back to the patient.
Yeah, that's wild. That's the second time I've heard that now, because that's what somebody was telling me yesterday.
Not real common, and especially, in the ER, we would do it because it's so much volume out of a chest.
Oh, we gave her like 5 units before she left.
A fluid or blood?
Blood.
Okay.
She was in blood and platelets. Well, we didn't we gave her like 1 unit of platelets, I think.
Yeah, but what was I gonna say? Yeah, but like on a knee, where it's not that it's a lot of volume per se, not like a chest. A chest is such a huge volume, but for people that are absolutely refuse blood products, doesn't have to be a religious thing. Some people just refuse blood products.
Yeah.
And we'll do them for cell savers, and there's a machine called a cell saver in the OR that any type of drainage that comes out of certain areas, they can actually send through the cell saver and give them back too. But that's a very specific machine in the OR.
That's
But
cool.
we have people that absolutely refuse blood products. It's still dangerous to do that, but there's ways that we can do it. And these are some of the other ways that we can do it is with these certain areas you can give blood back. But if we've got that, we can use auto transfusers to get that back. I've done auto transfusers many times out of the chest. I mean,
That's
I've been
cool.
I've been an ER nurse for a long time. You got to remember that. At a level 1 trauma center. So I've done pretty much everything a lot of times because I'm old. But
That's
okay.
cool though. That's the funny thing about Pineville though. It's like I hear a lot of these stories coming from Maine, and I'm like, right, but imagine doing that with almost no resources.
You know, probably somewhere there's been a nurse that has worked at a level 1 somewhere. They'll say, "Do we have an auto transfusion?" And you're like, "Oh God, it's been a long time, but I think I remember how to do it." You know.
Mhm.
You do. Okay, let me go through my list and see who maybe I missed. Kelly Lambert, are you here?
Yes, ma'am. I'm here.
Yeah, it's real funny when I sign you all off. If I click you too soon, I miss you because it clicks onto somebody else's name. How about Sarah McCann? I remember Sarah McCann. Sarah McCann, are you here? I don't. She might be on break. That's not fair of me to call. I'll give you all a break and then I'll start calling your name.
Hey, Janie. Nicole's in the waiting room.
I don't have anybody in my waiting room. I have no one in a waiting room.
Okay, I'll tell her.
Tell her to get up. She's not in my waiting room, so I don't know. I can't help her. Sarah McCann, are you here? You might be on break. I feel like I remember clicking her in.
I see her name on there.
Is your name on there?
Yeah.
Okay. I'm not accusing her, but sometimes y'all. Of course, I've been known to do it for meetings, so I'm not being critical of y'all. I've been known to sign in and then not be there. Oh, I see her name with it. I'll click hers here. I'm not saying it is break time. How about Victoria Parker? Tori, you here?
Yep, I'm here.
Okay. How about Catherine Parsons? You go by Katie?
Yeah, I'm here. I go by Katie.
Katie. Okay.
Yeah.
How about Demi Quist? You here?
She's sick.
She's not here. Okay. I signed in somebody's name that I didn't think was in our class. Ortega? Oh, that's Tori. Oh, I see you now, Tori. Okay.
Yeah, that is me.
Okay. I was going to ask who that was. Okay, let's get going. All right, so ABGs and compensation. Now, you learned ABGs in 152. First of all, let me just preface this by saying the workbook that is on Moodle is 99.9% harder than what's on the test. The test questions are probably going to be on ABGs are probably going to be the easiest test questions on the whole test. So I don't want you freaking out about the ABGs. The workbook is purposefully hard because I want you to think. I want you to sort of say, I kind of get this. So I don't want you to be freaked out about the workbook if you're having trouble with it. All right? It's made to make you think a little bit. I promise you that the ABGs on the test are probably the easiest questions you're ever going to have. I promise. Typically, they will be the ones that 99% of the class will get them right. There's somebody that didn't study them at all and don't understand anything about them, will miss them. But typically, they almost score that 100% of the class get them right. So I'm going to start out by saying that because I don't want you to be going, oh my God, oh my God. What I really want you to concentrate on is do you remember anything from 152 and do you understand what compensation is? And then the one little thing we're going to go at the end that is new that you do need to know. All right, so acid-base balance is determining the acid-base status of the body. It is not oxygenation. It is acid-base status. All right. Why do we care? We care because when the body is out of acid-base balance, hang on, I'm trying to get the different colors pad here. Because when the body is out of acid-base balance, it doesn't work correctly. The compensatory mechanisms don't work. So what are some compensatory mechanisms? Well, things like, oh, your blood pressure fell. Why don't I do some sympathetic nervous stimulations and release some epinephrine and make you vasoconstrict and shunt some blood back up to your heart? That's a compensatory mechanism. When your body is out of acid-base balance, things like that do not work. So how the body keeps itself alive works when you are in an acid-base balance. So the body is always striving to be in acid-base balance. When it's not in acid-base balance, that's when things don't work right. So being in acid-base balance is very important. So acid-base balance is important. Now your ABGs tell you different things, and you learned this in 152, and they do say oxygenation, but oxygenation is oxygenation. It is not acid-base balance. All right, it's oxygenation. It tells you a PO2. It's oxygenation. But what we're really dealing with is acid-base balance, is what we're typically looking at. Now, this next thing on the right-hand side is probably one of the most important statements of acid-base balance, and that is, it is used in conjunction with the clinical status of the patient. Do not be in a hurry to jump to the numbers. That's where you're going to screw up. Read the scenario. If I tell you, or if your patient has a breathing problem, then it's a respiratory. It's either respiratory acidosis or respiratory alkalosis. If it's a pooping problem, it's metabolic. We don't breathe poop. People that have been pooping for 4 days are not in a respiratory problem. They are in a metabolic problem. People that are vomiting, we don't breathe vomit. Okay? So pay attention to your scenario. It will narrow you down to 50-50. Then determine what's going on from there. Now, your workbook doesn't really give you scenarios. It gives you 2 scenarios in there. It gives you 2 scenarios with pretty much the same numbers after them. And if you look at the answers are completely different. Why? Because one of your patients is respiratory. One of your patients is metabolic. So figure out what's wrong with them from there. So that's why you got to look at your scenario. The other ones, I purposely didn't put a scenario with it because I wanted you to try to figure it out a little bit more difficult. On the NCLEX, listen to me. On the test, either it will have a scenario or the question didn't need a scenario. The question was it did involve a scenario. I promise you, they are very, very simple on the test. I promise. If not, you can say, Janie, you lied. And I don't usually lie. Not usually. I have been known to lie, but not very often. Okay, if it's a breathing problem, it's respiratory. If it's a pooping problem, it's metabolic. Doesn't have to be just pooping. Body. You either breathe it or you body it, okay? All right, now, these next slides, which I will not go over, explain respiratory, metabolic, respiratory alkalosis, metabolic alkalosis, okay? I've written this all down for you.
Could we see the pictures? I'm sorry, because that's not on our slides.
I'll put them up later. I'll put them up
Okay.
during break, okay?
All right, thank you.
Now, I don't know how, when 52 teaches it, I don't know how you learned it, but it's very important. I don't know if you learned arrows or a tic-tac-toe box, or there's lots of different ways to do this. The problem is, if you learned arrows or you learned a tic-tac-toe box, you're learning at a lower level question. You're learning, these are the numbers, what is it? Which might be okay, but a lot of questions are above that, especially on NCLEX. You've got to know what is what in an ABG. All right, so this is the most important thing. You know what a pH is? Normal is 7.35 to 7. Was that the slide right in front of it? Okay. Normal is 7.35 to 7.45. All right. Now this other thing about the bicarb, don't, I'm only at the very bottom right now. I'll come back and talk about this ratio in just at the very end, okay? But your normal is 7.35 to 7.45. If it's less than 7.35, they are acidic. If it's greater than 7.45, they are alkalotic. That's a normal value. You have to know your normal values, okay? So if I have an asthmatic patient who has a pH, first of all, I have an asthmatic patient. I say, that's respiratory. The next thing after the scenario, 100% of the time you look at is your pH. The next thing you look at is your pH, or the first thing you look at after the scenario is your pH. Are they acidic? Are they alkalotic? Or are they normal? If they are a respiratory client who's acidic, they are in respiratory acidosis. If they're a respiratory client who is alkalotic, they are in respiratory alkalosis. I'm done. I don't even have to know the other numbers. But we still look at them, but I don't have to know it. So
Janie, are we going to have to know like the full, if it's full compensation?
Yes.
Or,
I'm
okay.
getting ready to do it. Get ready to do it. Okay. Yes, you do. All right. So here we go. So that's what your pH is. Your PCO2, and listen to me. Don't be right and listen, is always acid. It is nothing but acid. 100% of the time, acid. It is acidic. Your PCO2 is acidic. Normal is 35 to 45. If it's greater than 45, then you have too much acid on board. It is acidic. If it's less than 35, then your acid is low and you have more base on board. So if the yellow is acid and the white is base, okay? The yellow is acid, the white is base. If my PCO2 rises, I have more acid in my body than I do base, so my patient is acidic. If my PCO2 drops, I have more base or more alkali in my body than I do acid, so my patient is alkalotic. All right, so it is acidic. It is always acidic. Your PCO2 is always acidic. So do I have too much acid or too little acid? And it only represents the lungs. Only. Doesn't represent anything but the lungs. The bicarb is always base. Always. It represents the body. Always. Has nothing to do with the lungs. It represents the body. If your normal's 22 to 26, got to know it, 22 to 26. If your bicarb is up, then I have more bicarb, more base than I do acid. Therefore, my body is alkalotic. Base and alkali are interchangeable terms. If my bicarb is less than 22, then there's more acid in my body than there is base. So my patient is acidotic. It's caused from the body side, not from the lungs. It's caused from the body side because I'm dealing with the bicarb. The bicarb is body. The PCO2 is lungs. Okay. You learned that in 152. That was a review. You learned that in 152. Now, compensation is a buffering system. If you want to call it neutralize, call it neutralize. It's not quite neutralization, but it's good enough, okay? In order to neutralize it, the opposite system has to neutralize it. And why do we neutralize it? To get us back into balance, because the body wants to be balanced. All right. So if for some reason I am not breathing well and I increased my PCO2, I don't breathe well, I don't blow off my CO2, I'm keeping it inside my body, my CO2 is rising, my CO2 is rising, my CO2 is rising. And it's a breathing problem, I am now in respiratory acidosis. In order to neutralize it, my bicarb has got to rise and neutralize it. Compensation is not fixing the problem. It's not making me breathe better. It is simply getting my blood neutralized. I may need to fix the underlying problem. Yes, I do. But that is not what acid base is. It is not fixing the underlying problem. It is neutralizing my blood's pH. All right, so if you determine that they have too much respiratory acid, that would be respiratory acidosis, then the bicarb has got to neutralize for a respiratory problem. The opposite system has to do the neutralizing. If it's a metabolic problem, so you should know that your vomit is acid and your poop is base or alkali. That's a pathophysiology thing. When you vomit, your vomit is very acidic. Okay. When you poop, your poop is base. So let's just say, okay, let's just say that you're vomiting. All right. You're vomiting. And therefore, because you vomit, you start to lose your base because you're vomiting out your base. Okay. You're losing your base. No, that's not right. It's acidic. You're vomiting. You're losing your acid. Okay. This is metabolic acid, but you're losing your acid. I said that wrong. Of course I did. Your patient that is vomiting because they're losing acid, your vomit is acid. You're losing bicarb, you're vomiting bicarb. It's still acid, but it's you're vomiting. They are in metabolic alkalosis. You lose acid, you are in metabolic alkalosis. What's inside the body? The blood test, we're running blood outside the body. You're in metabolic alkalosis when you're vomiting. How do I neutralize it? I have to neutralize it on the respiratory side. I have to get my CO2 to rise. I have to hypoventilate and it has to rise.
Hey, Janie.
Hmm?
I'm so sorry. Nicole is now in your waiting room. Thank you. Sorry.
Oops, I'll go back. I know I was on the wrong thing. Oh, wrong. I went the wrong direction altogether, didn't I? Okay, the opposite system has to neutralize it. So if it's a metabolic problem, the respiratory system either has to hyperventilate by blowing off acid or hypoventilate by retaining acid. If it's a respiratory problem, your kidneys either have to pee out bicarb or send that bicarb back into your bloodstream, retain your bicarb. The opposite system must buffer. I didn't make it up. It's pathophysiology. Now, when this happens, it doesn't happen at the same rate. If it is a metabolic problem, your kidneys, wait, let me start again. If it is a metabolic problem, when I teach this, I really have to listen to myself. If it is a metabolic problem, your lungs will start to compensate within a few hours. Okay, so you get into a metabolic acidotic state. You're a diabetic. And you go into DKA. You start breaking, your sugar goes up, you start breaking down ketones, okay? And so you get into a metabolic acidotic state. Your ketones made you acidic. Your lungs say, I got to compensate. They're in metabolic acidosis. I've got to compensate. Your lungs will start doing Kussmaul's. And they will compensate within a couple hours. If it is a respiratory problem, so you're a COPD patient or an asthma patient, and you're not breathing, you don't breathe well, you don't take deep breaths, you don't exchange air well, so your CO2 goes high. And you all know that a COPD patient's CO2 is high. You all know that. So a COPD patients, people that don't breathe well, retain their CO2. I mean, that's a common known fact. When you don't breathe well, your CO2 is high. How do I neutralize it? The bicarb has to rise. So what does your kidneys say? Your kidneys say, don't send that bicarb out in the urine. I will send it back into the bloodstream, and the bicarb will rise and come up and neutralize it. It will take 2 to 3 days before the kidneys will start to reabsorb or excrete bicarb. 2 to 3 hours for the respiratory to start working. 2 to 3 days for the kidneys to start working. Okay, so how do we look at this? How do we look at compensation? All right. When you look at it, you start and you do it the same way. You read your scenario always. You look at your pH. You say, is the pH acidic, alkalotic, or normal? Okay. So let's leave the normal alone for right now. We're going to say, is it abnormal? So yes, we're going to say our pH is abnormal. So it's either acidic or alkalotic, either one. Okay. So we're going to say yes, our pH is abnormal. The next thing you go to 100% of the time is your PCO2. So I should already know what they have from my scenario and my pH. I should already know, but okay. So let's just say it was a respiratory client and the pH is acidic. I already know they're in respiratory acidosis. But if it's respiratory acidosis, then my respiratory acid has to be high. So I go to my PCO2. And my PCO2, normal's 35 to 45. And their PCO2, I'm just making this up, is 50. So their respiratory acid is high, just like it should be. If it is uncompensated, my kidneys, my bicarb, my HCO3 will not have started to move out of normal to fix it. So my bicarb will be normal, which will be 22 to 26. Okay, so my PCO2 went up. That made me in respiratory acidosis. That changed my pH to acidic. And my bicarb has not moved out of normal. That is an uncompensated ABG. Respiratory acidosis, uncompensated. Now, I got another patient. The pH is abnormal. We'll say it's a respiratory patient again, just for simplicity's sake. The PCO2 is 50. And my bicarb is 30. My PCO2 is up. That made them acidic. And now my bicarb, which is normally 22 to 26, has risen to 30. It is out of the normal range, but it hasn't neutralized it. The reason I know it's not neutralized is in order to be neutralized, it has to bring your pH to normal. And my pH is not normal. My pH was abnormal. The third one, I got same patient. I got a pH that's 7.38, a PCO2 that's 50, and a bicarb HCO3 that's 34. Now, my PCO2 went up, my bicarb went up, and it brought my pH back to normal. This is a fully compensated ABG. So here's the rules. Write them down on your piece of paper. You ready? Here we go. If the pH is normal, 7.35 to 7.45, the PCO2 is normal, 35 to 45, and the bicarb is normal, 22 to 26. It is a normal ABG. If the pH is abnormal, meaning outside of the normal range, one of the other ones, either a PCO2 or bicarb, one of them is abnormal and one of them is normal. It is an uncompensated ABG. Okay. If the pH is normal, no, I forgot partially. Go back. The pH is abnormal and both of the other ones are abnormal. It is a partially compensated ABG.
Wait, I'm sorry, can you say that again?
If the pH is abnormal and both of your other values, your PCO2 and bicarb, are abnormal, it is a partially compensated ABG.
Was the pH normal or abnormal?
Abnormal. And the last one is if your pH is normal and both of the other ones are abnormal, it is a fully compensated ABG.
I have one question for you, Janie.
Okay.
Say it's a situation where we're in a partial compensation. Both of the other values are abnormal. For us to figure out what the problem is, if it's metabolic or a respiratory issue, would you also then provide us with details about the patient?
Well, maybe not. That one's easy. That's easy because you look at your pH and because it's abnormal. If it's partial, your pH is abnormal.
Right.
So let's just say your pH is, which way do you want it? You want it high or low? You want it acidic or alkalotic? Take your pick.
Acidic.
Acidic. Okay. So your pH is 7.28. Okay. 7.28. Then I go to my PCO2 and you want it high or low? Take your pick.
High.
Okay. So my PCO2 is 60.
Okay.
I know that is acid and I know it's respiratory. So my patient is acidic. My respiratory acid is high. This patient is in respiratory acidosis. That's all it can be.
Okay. So
Then my bicarb, HCO3, in order to partially compensate it, my PCO2 is up. Then my alkali, to partially compensate it, is not going to be low, which would make them acidic. It's going to be up. So my bicarb is going to be 30. So they went up, They went up, but they didn't neutralize. It doesn't matter. I mean, the only one you wouldn't know without a scenario would be a fully compensated. Because from the pH, you don't know if they're acidic or not. That's the only one you wouldn't know. Truly, it's the only one you wouldn't know. But they're not hard. They really aren't. But if you looked at this, if I didn't give you a scenario, you'd say patient is acidic. Look at my pH. Patient is acidic. Their respiratory acid is high. That respiratory acid made them acidic. So they are in respiratory acidosis. And then you look over at their bicarb. Their bicarb is high. Their alkali didn't make them acidic. A high alkali didn't make them acidic. Only a low alkali can make you acidic, not a high alkali. A high base can't make you acidic. A low base makes you acidic.
Okay.
So it has to be respiratory. Your PCO2 is always respiratory, always respiratory, always respiratory.
So, from what I'm understanding,
I know it's break time. If you all want to ask questions, I'll sit here as long as you want to ask questions. If you want to go to lunch, go to lunch. Okay, go ahead. Go ahead.
So if what I'm understanding is right, in partial, your bicarb will be low, like for metabolic.
Acidosis.
Yeah.
But not for alkalosis.
Right. I'm just trying to understand, like you were saying, like every time if the PCO2.
You want it to be a metabolic problem instead of respiratory? All right, then let's just make it a metabolic problem, okay? Let's go 7.28. So they are acidic, all right? 7.28, they are acidic, all right? Then your PCO2 is 28. A normal PCO2 is 35 to 45. So but they are acidic. I mean, go back to your pH. This patient's acidic. I can't change that. They're acidic. My respiratory acid is not high. The respiratory system did not make them acidic. So it has to be the metabolic side that made them acidic.
Okay.
So it has to be, if this is acid and this, it has to be because they dropped their bicarb. So their bicarb, their HCO3, which is normally 22 to 26, is 15.
Yeah.
So they're in metabolic acidosis. All right. So it's their bicarb that made them acidic. Okay. So they're in metabolic acidosis. Did their PCO2, did their opposite system, has it started to compensate? Yes or no? Has it left normal?
Yes.
Yes, it has, because normal's 35 to 45. So has it completely compensated?
No.
How do you know that?
Because of the pH.
Because the pH isn't normal. So this is a partially compensated metabolic acidosis.
Okay, thank you. That makes sense.
But it won't be
Miss
that hard.
Janie?
It won't be that hard on the test. Yes.
Do we need to know the 20-to-1 ratio?
Yes, but I'll do it after lunch.
Okay.
But the answer is yes, you do. But I'll spend the first 5 minutes after lunch doing it. More questions? Oh, believe me, I'll spend the next 2 days before the test answering questions online. And it's okay. It's all right. And it's because you're not understanding that PCO2 is respiratory and PCO2 is acid. That's why you don't understand it. You don't understand what's happening in the body.
I think the hard part for me is, for some reason, where I'm getting confused is when the compensation comes in. Because if I look at the problem and I see the pH, then I look at the PCO2, it's abnormal. Then I look at the HCO3.
You got to look at the pH is first. Look at the pH. And did the PCO2 cause it? You're skipping that piece.
Okay, so you have to start there.
So give me a pH. I mean, high or low? Give me a low pH. If your pH is, give me a high pH. Let's go 7.5. Okay. So you say to yourself, that is alkalotic.
Right.
Okay. That's alkalotic. Then you look at your PCO2. Always, it's acid. Their PCO2 is 60. A high respiratory acid does not make you alkalotic.
Got it.
It can't. You can't have a high respiratory acid and it be your problem.
Okay. That makes sense.
So you got to say, well, then it has to be on the metabolic side. So what would that be for an alcohol? Then your bicarb has, which is your alkalosis. If they're alkalotic, then my bicarb has to be high. And sure enough, their bicarb is 36. So the bicarb is high. So what has your respiratory done? It's moved up to try to neutralize it.
Okay, that I
But
get it now.
it's not fully because it didn't bring your pH back into normal.
Okay.
So let's look at so you got to say, what is the pH and did the PCO2 cause it or not? If they're acidic and your PCO2 is high, yes, it did. If they're acidic and your PCO2 is low, no, it didn't. It's always acid and it's always respiratory. Well, we don't say always very often. Always.
Well, that helps. It makes more sense now.
Always.
Hey, Janie, I have a quick question. With full compensation, because that's when we need to look at the scenario more. Is that what?
Well, as a whole, yes, because yes.
Okay, but is it going to be more like, because in the practice problems I did them, and so it was a little confusing because the pH was 7.40 was in the middle. And so do I need to look more at
scenario tell me what the first scenario told you. Do you remember?
Well, I know, if, for example, if there's too small respirations, or if you look like a ventilator, respiratory,
Shirley, what was the first scenario? Do you remember? I don't have it in front of me. Somebody tell me.
I don't have it, but I can.
Anybody
have it with me, but that question didn't have a scenario.
I have the sheet. Sorry.
There was a few that had scenarios, and so that's why.
But you're talking about number 4, and number 4 didn't have a scenario. It was just numbers.
But typically, if they're in respiratory acidosis,
the PCO2 is really high.
Typically, if the PCO2 is high, I mean, think about all your COPDers for 40 years. They almost always compensate. So if your PCO2 is high, usually it's respiratory acidosis.
Okay, so one is going to be more, even if they're compensating, one's going to be more extremely higher than the other. Is that what you're saying?
Mm-hmm.
Even if they're compensating, if their pH is normal, if the CO2 is higher and their bicarb is compensating?
Well, it's not apples and apples. So I don't know. So, but typically people that are in respiratory acidosis, which is long-term respiratory problems, compensate easily.
Okay, but that's when we're going to use
a lot of fully compensated respiratory acidosis. We see a lot of it. All your COPDers, all your asthma patients typically are in a fully compensated respiratory acidosis. Now, logistically, yes, logistics is a good word. I mean, realistically, that's probably a better word. Realistically, if you started hyperventilating,
that's
anxious, your boyfriend left you and you have a test tomorrow and I'm anxious, I have a history of anxiety anyway, and I'm having an anxiety attack. You start blowing off your CO2.
That's alkalosis, yeah.
You are in a respiratory alkalosis, correct?
Yeah.
A low PCO2, correct?
Yeah.
Your kidneys will not kick in for 2 to 3 days, and you cannot realistically hyperventilate without stopping for 2 to 3 days. You're either going to fall asleep, going to pass out, going to do something. It is almost impossible to hyperventilate for 2 to 3 days and be fully compensated in a respiratory alkalosis unless you're on a ventilator. And we are hyperventilating you on purpose.
Okay, there was a scenario that talked about like hyperventilating a patient.
Head trauma or a cerebral hemorrhage.
Yeah, that one.
And next week, when I talk about increased ICP, and I talk about one of the things we do is we put them on a ventilator and we hyperventilate them because CO2 is a vasodilator and it causes increased ICP. So we put them on a ventilator and we hyperventilate them. So that patient, we do hyperventilate them for days and days and days. So that patient will develop respiratory alkalosis. And they will begin to fully compensate because I'm going to hyperventilate them for greater than 2 to 3 days. But in reality, could you not on a ventilator hyperventilate for 2 to 3 days? You could not do it. You could not do it. It's virtually impossible to do unless you're on a ventilator. So when we see that, do I think it's respiratory alkalosis? I never think it's respiratory alkalosis. But do we have fully compensated respiratory acidosis? All the time. All these smokers are in fully compensated respiratory acidosis. All these bad asthmatics are in fully compensated respiratory acidosis. It's often fully compensated. But respiratory alkalosis is rarely fully compensated. Renal failure patients. Renal failure, it's metabolic, it's not breathing, it's metabolic, and they are very acidic. You know what? They have that pyruvic acid, that uric acid, that lactic acid buildup, and they tend to be on the acidic side. They're in metabolic acidosis. And I mean, we also treat their underlying cause. So they might not, but they often have a little bit of an increased respiratory rate. Not a huge respiratory rate like Kussmaul's, but they often breathe a little bit faster than most people do. Your renal failure patients breathe just a little bit faster because they're often trying to blow off a little bit of CO2 because their bodies are often a little bit more acidic. Why do your diabetics go into Kussmaul's? They're breaking down their ketones. They go into diabetic ketoacidosis. It'll kick in 2 hours. Their problem is metabolic, but then they're blowing off that CO2. Their body's trying to compensate. The opposite system. So it may not have numbers may not have the scenario, because that would make it too daggone easy. I wanted y'all to think a little bit. Is it that hard on the test? No, it is not. I promise you it's not. I swear to you it is not. It's not, I promise. Because I know this is tough. I mean, this is a little higher level. It is. It's not going to be that difficult. Okay? I promise. I wouldn't do that to you. Except for those of you that really don't like me. And then you probably say I'm an old, mean old woman. You know, fat one. Old and fat and mean. But I'm not. My bite's a lot worse than, my bark's worse than my bite. Any other questions?
Do we come back in the burn?
I'm going to do the carbonic acid, CO2 carbonic acid ratio real quick. It'll take about 5 minutes. And then we're going to do burns.
Well, I meant like when we come back from lunch, are we going straight into the BERM Zoom link, or are we doing, because there's 2 different links, I believe, when we come back from lunch.
For the slides? Is that what you're saying?
No, like we have Zoom links. And so I believe.
Oh, no, we'll come back in the other link. Yes, we come back in the other link. Yes.
Okay.
I'll have to sign out of this one and go into the other link. Yes, that is correct.
Okay.
I'm a little slow sometimes.
That's okay.
Anybody else? All right, everybody leave. I'll sign in under the other one, okay? Have a good lunch. Eat something real quick. I'm going to get something real quick too. Bye. Can't get out of it. Come on, you can do it. Here we are.